We're talking about reperfusion rhythms, and for our context, we're going to talk specifically about ROSC. Often, when we're talking about reperfusion rhythms, we're talking about someone who's undergone PCI or thrombolytic therapy, and as a result, we've seen an ischemic heart start to restore blood flow. Now, we know that in cardiac arrest, the lack of blood flow to the heart can lead to ischemia, and as the heart begins to beat again and we start to have cardiac output, it could lead to a reperfusion rhythm. So again, not the most common case if we think about cardiac arrest and what's happening in cardiac arrest. A lot of patients are going to be having fairly extensive damage that is not going to be reperfused. But there are patients who the lack of blood flow as a result of cardiac arrest can lead to poor perfusion, and we can see reperfusion as the heart kicks in again. So we're going to talk about that. So I've got an ECG here, and what I want you to do is take a look at it, basically write down the key features that you see on it, and make a diagnosis of what you think you're seeing in lead 2 here. And we'll kind of use this to guide our discussion about some of the reperfusion rhythms that we might see. So if you want to, you can pause the video here, zoom in on the ECG, and make some decisions. So hopefully if you've done that, you've picked up on a couple things here. One is the rate, and the rhythm that we're going to be looking at here can often have a rate between 40 and 120 beats per minute. Right here, what we're seeing is a rate of 75 beats per minute. So we're kind of right in between the norm of what we see for this type of rhythm. The other thing that hopefully you've noticed is that we have a wide QRS complex. So our QRS complexes are wide, which is important here. So we have a wide QRS at a rate of around 75 beats per minute. What can happen sometimes is this can be misdiagnosed as a ventricular tachycardia, especially because this type of rhythm can be generated from anywhere between 40 to 120 beats per minute. But its rate and the width of the QRS and the absence of P waves, and you might be saying, well, I actually see a few P waves here, which there are some. So for example, here there's an escaping P wave, but we don't have a general association between P waves and the QRS complexes. So this would be kind of like an escaping P wave or a non-associated P wave. So if that's the case, then this is likely an idioventricular rhythm, and that's what we're looking at is an idioventricular rhythm. Where people sometimes can get mixed up is we know that some of the key characteristics of VTAC are things like fusion or escape beats, and we actually see a couple of those here. So we're looking at here, they don't look like the typical QRS. So these are fusion or escape beats, which are not uncommon in a myocardium that has an increase in automaticity. So fusion or escape beats are typically happening because we have ectopic tissue or tissue outside whatever the normal conduction pathway happens to be right now that is looking for or is going to have some sort of increase in automaticity. So we can see fusion or escape beats. So what this is a accelerated idioventricular rhythm. So we're looking at an accelerated idioventricular rhythm. And there are, a few defining features of an accelerated idioventricular. So one is we have a wide QRS complex. So we have a wide QRS with no associated P waves. In these rhythms, you can sometimes see dissociated P waves, so a P wave that's escaping or not beating with the QRS complex. The rate is important here, and this is one of the biggest differentiators between a VTAC. So accelerated idioventricular rhythm is considered basically anything that's wide with no associated P waves between 40 and 120 beats per minute. So over that 120, that's typically when we're going to see our VTAC. And what's important to recognize is that the presence of fusion beats or escape beats is not going to be a pertinent negative for accelerated idioventricular. So we can see escape beats or fusion beats. What you may be thinking is, well, why does it matter? Why does it matter if the heart rate is 118 and it's wide? Can I just call it a VTAC? And there is some rationale for trying to differentiate between a VTAC and an accelerated idioventricular, and a lot of that has to do with the cause. So cause is typically different. So when we're looking at an accelerated idioventricular rhythm, what's happening is we're truly seeing ischemic tissue reperfuse. So we have ischemic tissue that is resulting in, or what we're going to have is some reperfusion. So the purple kind of blob I've drawn here, this is ischemic tissue. And that's important to differentiate from a scar tissue. So we're looking at, necrosis or infarcted tissue that actually has scarring. And that is the big difference here between a ventricular tachycardia and someone who's in an accelerated idioventricular rhythm, is that someone who has scar-induced tachycardia, so we have scarring that's resulting in ventricular rhythm, that's typically going to lead to reentry tachycardia or VTAC. Whereas when we have ischemia that is going to be subject to reperfusion, then we're often going to see accelerated idioventricular rhythm, which A, is often more benign, and B, typically self-terminates. So we actually see correction on its own. So when we're thinking about intervening for these patients, we want to be mindful of the fact that if this is an accelerated idioventricular rhythm, we may not need to perform any immediate interventions. So perhaps this patient is not a good candidate for synchronized cardioversion post-arrest because it's accelerated idioventricular, it's a common reperfusion rhythm, and we expect it to hopefully terminate on its own if perfusion is accomplished. So let's talk about that a little bit. So when we're looking at the accelerated idioventricular rhythm, the most common cause or the pathophysiology that we're seeing here is that we're looking at ischemic tissue that's being reperfused. So we have ischemic tissue that's being reperfused. And this creates a couple of physiological features for this patient that lead to the rhythms that we see. One has to do with potassium. So one is going to be potassium changes when we're looking at reperfusion. If you think about what's happening, if we draw on one of our myocardial cells here, so this is a myocardial cell, it's underwent some ischemia, so we've got some damage to the cell wall. And potassium is our major intracellular ion, so it can escape. So we actually start to see some potassium escaping from the cell, which can lead to an increase in our resting membrane potential, and it can bring the cell closer to threshold. So one of the things that is going to promote accelerated idioventricular rhythm is alterations in potassium flow as we have potassium exiting the cells. The other thing we have to be considerate of is that if this tissue was deprived of oxygen, things like our ATP pumps are not going to work. So if this is one of my ATP pumps, and one of the functions of that ATP pump is actually to move calcium outside the cell, we can actually see an increase in intracellular calcium concentrations. So we start to see this big increase in pooling of calcium within the cell, and that too can increase automaticity. So potassium changes and calcium changes are often associated with an increase in automaticity for these patients, which is often why you see this accelerated idioventricular rhythm. So we're waiting for the SA and the AV node to be reperfused, or maybe there's some damage there that needs reperfusion. We have ventricular tissue that is prone or susceptible to irritability, and we're seeing that tissue that has likely been ischemic having potassium release, the calcium pumps weren't working, which are going to increase automaticity. And that is a big difference. So increase in automaticity is a big difference than a re-entry tachycardia. So again, when we're talking about something like VTach, that's often going to be the result of scar tissue in the ventricle, which is leading to reentry tachycardia, which can cause VTach. Totally different story compared to someone who simply has an increase in automaticity because my myocardium wasn't getting enough oxygen and potassium was leaking out, calcium was building up inside the cell. Well, that can be corrected. When we're talking about someone who is reperfusion or having reperfusion, those things are correctable, which is good. So often what we see with this patient is if reperfusion is successful, we start to see correction. And that's why with these patients, if we're looking at accelerated idioventricular rhythm in the post-arrest, we want to manage things like oxygenation. We want to manage things like blood pressure and attempt to achieve as best perfusion of the heart as possible, because if that's the case, we should get correction. So one of the things we'll see is if we get an increase in oxygenation to the tissues, what we should do is correct the potassium and the calcium imbalance. So we're going to correct that potassium issue, we're going to correct that calcium issue, and hopefully we can prevent the increase in automaticity. The other thing that you can see for these patients is that increase in O2. So as we increase O2 status, we start to better perfuse the SA node and the AV node. So we increase oxygenation to the SA node and the AV node, and eventually the more regular conduction system takes over. So if we can get those nodes working, they begin to take over as the pacemaker. So we think about treatment or how we are going to proceed with these patients. Often what we're looking at is observation. So we want to maximize post-arrest care. So what are the things that are going to be most beneficial for this patient is often we're simply doing the things that are going to maximize perfusion. So when you look at how does this direct my care, what you want to start thinking about for this patient is increased perfusion. So what that means is managing blood pressure, oxygen saturation, offloading of CO2, so increased perfusion, increased oxygenation, and hopefully we'll see termination of that rhythm. So all of the things that we know matter in post-arrest care matter here. So blood pressure support, whether that's with fluid or a vasopressor like dopamine, whether that is going to be oxygenation of the patient targeting that those saturations we're looking for, as well as our end titles. So perfusion and oxygenation are important. What we typically are not going to do here is give antiarrhythmics. If we think about what is happening, the challenge that can exist with an antiarrhythmic is that we start to abolish the automaticity in these tissues. You decrease this automaticity before the SA node or the AV node has a chance to be reperfused. And that could result in either rhythm termination. So we may not see a rhythm generated at all, or we can degenerate into a more malignant form of VTach. So as we stop these systems from working, we do allow that scar tissue that may have formed for this patient to generate that reentry tachycardia. So antiarrhythmics typically not preferred in patients who are experiencing an accelerated idioventricular rhythm from reperfusion. Finally, you can look at cardioversion of these patients, and generally it's not indicated. So if it's non-malignant and self-limiting, often we're not cardioverting these patients because it's going to result in correction on its own. And the other piece to this would be Well, what if I'm uncertain? And that's where we always go back to Heart and Stroke Foundation guidelines or ACLS guidelines. And if you're uncertain, if you do think that this is a reentry tachycardia from VTAC, then you could cardiovert that patient. But you have to make the decision, and that's where I think that taking the time is important when we have the ROSC patient, the post-rest patient, to do a good assessment. Let's get a blood pressure. Let's get a 12 lead. Let's ensure that the things that matter post-arrest are being managed. So things like oxygenation and blood pressure support. And often that's going to slow things down, give you enough time to look at the rhythm, think about the clinical presentation of the patient, and then make a decision about what would be the most appropriate action. But if we think we're looking at a true reperfusion rhythm or an accelerated idioventricular, then typically these are the things that are going to matter. And something like an antiarrhythmic can actually do more harm and actually devolve into a malignant tachycardia. And something like cardioversion is typically not going to correct the issue because this is the tissue that's functioning at this point, and we just need time to reperfuse it. So something to be mindful of. So one of the things you can start thinking about is how does clinical presentation play a role here? Is that you're less likely to see these rhythms in someone who is having massive STEMI, for example, who has extensive structural damage to the heart. So if I have long-term cardiac ischemia or acute coronary syndrome, I have heart failure, I've had previous MIs, or I'm having a massive heart attack today, chances are that I am going to have lots of scar tissue, and I would use that clinical information to make some decisions about this patient if I'm not sure. If the rate is high and I'm not positive whether this is an accelerated idioventricular rhythm or a VTAC, then I will use some of that information to make this decision. But we want to be really mindful in a lot of these patients. Rate is important. So 40 to 120 is typically going to be accelerated idioventricular. And if it is accelerated idioventricular, we want to start thinking about what is the cause. And if it is reperfusion for this patient, then oxygenation and blood pressure support are going to be the critical findings or the critical things we want to do. We don't have to rush to something like antiarrhythmic, which can make them worse. We definitely don't have to rush to something like cardioversion, which is likely not going to play a role here. So I do have other rhythms on the pathophysiology of or other videos on the pathophysiology of VTAC. I'll put those up here, but this I think is one of the things I want to talk about so that we slow down our post-arrest management of patients and we really start thinking about what is actually happening here, what is the rhythm, and how do I know?